Let's bring down Jan Jansen now, who's going to talk to us about this evidence-free zone in the intensive care unit with regards to Ebola.
Yeah, thank you very much, Johnny. Excellent talk. I think back to planet Earth now. Nice concepts. So yes, evidence-free. Have to say, I did a bit of a search on this, and as you've probably gathered by now, I'm kind of an evidence type of guy. And I found very little on the ICU management of Ebola patients. So I'm afraid this is all just going to be a little bit of extrapolated stuff from other settings, and in particular, I guess, from the management of patients with abdominal aortic aneurysms. You could argue, is this all common sense? But there's a problem with that. I think we do have to be careful about common sense, and I've already in some of my other talks alluded to that today. A lot of the other things that we used to think were really good and made a lot of sense and stuff that we should be doing because, yeah, it just seemed right, end up not being quite that way. So I do think we have to be very careful about all of this, and ideally, in the future, we do want some more research on this. I think clearly what you want when you receive a patient in the ICU who has had Ebola is you want a really good handover, both from your surgical team and from your anesthesia team. And probably one of the most important things you want to know, is that balloon actually still up, or has it actually been deflated and taken out? But you want to get, ideally, all the other details as well. You want to know when the balloon went up, how long was it up for, was it a partial occlusion, was it intermittent, were there attempts at deflation? So all that stuff is really important, and clearly something you should be trying to get. And then there are a few issues, and there are 6 of them here that I've listed that I think are probably really important to all this. So the first one is resuscitation. And really, for a few years now, we've been talking about this concept of damage control resuscitation, with resuscitation starting in the emergency department, continuing while the patient is in the OR, and then secondary resuscitation in the intensive care unit. And probably one of the most important realizations from the war in Afghanistan and in Iraq was that you can actually resuscitate patients while they're in the OR still. So this old paradigm of patients will only get worse in the OR is probably no longer completely true. But you do have to work pretty hard if you're going to do that. And if you've got a patient who's had Ebola, then it is almost certain that there will be an ongoing resuscitation need, because there will be a debt that you will have to repay when you're in the ICU. And that's okay, because that's what we do. How do you do that? Well, you resuscitate them, probably, again, with blood and blood products. I think this is probably not the place to try giving lots of crystalloid or colloid and things like that. You probably want to stick with what we know, and that's a ratio somewhere around the 1:1:1. And then you've got to look out for your endpoints of resuscitation, and they're quite important, actually. And certainly what I think is what matters to me is whether the patient is still coagulopathic, whether they're still acidotic, whether they are still hypothermic. So the classic kind of lethal triad of trauma. Hemoglobin is definitely not an endpoint of resuscitation. I think chloride is a negative endpoint of resuscitation. You don't want to end up with a chloride of 125. But these are the kind of things that you need, and really you want to have a global assessment of patients. Clearly, patients who are on lots of vasopressors probably also have ongoing resuscitation needs. And I think this is probably one of my sort of pet fears when I walk into the ICU and trauma patients come through from theatre, and I get told, oh yeah, the patient is stable, but they're still on a load of noradrenaline. So I think these are all the things that you have to take into consideration and really form a global assessment of whether this patient is resuscitated or not. Now, along with that, you need to think about the monitoring. And, well, a lot of people think that's what we do in ICU, we just monitor patients. I have a fairly hands-off approach to monitoring, actually. I don't think you need a lot of monitoring, especially in the setting of after hemorrhage. You probably need an arterial line, no question about that. You probably have that anyway if the patient's had Ebola. And then, yeah, you need some venous access, and that might well be central venous access, but I don't actually look at central venous pressures in the ICU at all. But I think what's important here is, again, is this concept of the expected clinical course. You want to have an idea of where these patients should be heading, and if they're going off that trajectory, that's when you need to worry. And I think that's really key to actually spotting when complications supervene. So it's about keeping it really simple. Monitoring does not have to be complicated. don't need PICO, LIDCO, PA catheter, whatever. But if you really end up in trouble and you really don't know what is going on, then I find that a bedside echo is probably the most useful investigation that you can get, and ideally repeated actually. Post-reperfusion syndrome, systemic inflammation, Johnny's talked about a great deal already, so I'm not going to say much about that, except that expected, it is going to happen, and you'll probably get all of these things. And the most important thing is, as Johnny already alluded to, there are no specific treatments. So this is just something that you're going to have to ride out, you're going to have to support as best as you can. And then really, it comes down to anticipating complications. And you can probably divide those, expect them as well, divide those into ones related to the access side, and we've heard a great deal about those at this conference already, and those relating to the lower extremity. And I think what's really interesting from all the studies that we've heard about is that there is really a great deal of difference between the studies in terms of the reported rates of lower extremity complications. Certainly the experience from London seems to be that there have been quite a few patients who've developed thromboses and even had problems with limb loss. So I think that's very, very important to be aware of that and something to seek out. So if there's any doubt at all that your patient is having a problem with the lower extremity circulation, then start looking for it rather than just sitting. If in doubt, image the patients for sure. Think about other things as well. So if the patient's had zone 1 ROA, then yeah, mesenteric ischemia is clearly something to look out for as well. And as we all know, that's difficult to spot at the best of times. If you've got a patient who's got a really good going reperfusion injury and lots of systemic inflammation, that is really, really hard to spot. And this is where this idea of the expected clinical course comes in. You need to be really aware of what's going on and frequently have a look at the patient. Acute kidney injury, yeah, for sure, likely to happen. Don't forget about the associated injuries, because I think we've become, especially in this conference, we've talked a great deal about vascular control and all of that, but trauma patients do not just have vascular injuries, so you still need to be aware of everything else that is going on with the patient as well. So, in summary, I think looking after patients like this in ICU is all about doing the simple things well. It's what we do in ICU anyway, but we just got to do it especially well for these patients. And I think we do need more research. Thank you very much.
You talked just briefly about the use of bedside ultrasound. One of my favorite tools, poor man's transthoracic, limited view utilization of it gives you dynamic information that can be eminently repeatable. What, do you utilize that? Who does the echoes, the bedside echoes in your own institution?
Yeah, good question, and a mixture actually. And I don't consider myself to be a very proficient echocardiographer at all. I use it mainly to assess the preload, the IVC, and to get a bit of a global assessment of contractility. But often I find that is actually pretty useful. If more than that is needed, there are some intensivists now who are properly trained and accredited in echocardiography. But failing that, ask a cardiologist. Now, it's sometimes difficult to get a cardiologist to come along every hour, but we can all hope. Where's Paul?
One here and then in the front. Yes, sir.
What's your criteria for taking the patient back to the theater if there's ongoing bleeding and you're wondering, is this serious or just aftermath of the treatment? And how many units of blood, fresh frozen plasma, platelets you allow before taking the patient back?
Yeah, good question. And I don't think there's an answer to that. I think again there's global and frequent reassessment that's required. I don't think you can really say a patient who's needed 6 units of blood or 12 or 2 needs to go back. But I think the difficulty with these patients, and in a way this pertains to all ICU patients, is of spotting that unexpected clinical course when things are not going right. And I think that applies particularly when you have problems like acute kidney injury, supervening, when you then can't really use things like the base deficit as effectively as you could before.
And we had a question in the front.
I want you to comment on, if you use a REBOA, you manipulate the blood pressure a lot, but you also manipulate the partial pressure of carbon dioxide because you close a lot of vessel beds. Do you think it's important if you have a multi-trauma patient with also intracranial bleeding Is it because the cerebral circulation is very sensitive to the partial pressure of carbon dioxide? Is it important to monitor carbon dioxide when you use the Reboa and when you release it?
Yeah,
Or is it
for sure, and it's something that I would hope is fairly closely followed in intensive care units anyway. But of course, the
in the initial resuscitation? I mean, in the intensive care, of course, it's followed.
it is, but you have to bear in mind that, of course, what you're seeing, especially on the end-tidal CO2, as we heard earlier on today, is not only related to the respiratory status, but also very much to the metabolic and circulatory status. So, but yes, absolutely, I agree.
Thanks.
Thank you, Jan.
Thank you.